Hello, today we're going to have a chat to Laurie Delany, who's a senior lecturer at the University of Canberra, and has great expertise in critical care nursing, has taught extensively at other universities and has worked in a number of different clinical environments. Today we're going to be talking to Laurie about her experience and hopefully she'll be able to give us some insights as to how important it is to have a wide open mind for a critical care practice and how practice and cultures can vary between various institutions. And so the expectations of a critical care nurse as they're going out, having only ever worked at one hospital, may differ as they go to another hospital. So thank you, Laurie. Would you like to just tell us a little bit about yourself and your clinical background, please?
I graduated my nursing degree in 2002, I think it was from memory. I studied at Monash and did my graduate at the Alfred Hospital in a respiratory ward, and then from there went to ICU and finished my postgrad dip in 2005. So I spent probably 5-6 years at the Alfred working there in a clinical specialist role, and then decided to spread out and go and work in a variety of different other areas. So I've worked across quite a few different areas in metropolitan and regional Victoria, regional New South Wales, Queensland and the Northern Territory. So my experience in terms of variety of critical care environments is quite extensive. Not worked overseas, so very much just Australian-based experience. I suppose the thing that's you tend to see that's quite different amongst ICUs is the roles in which nurses work within. So some ICUs you see are very autonomous, and that's certainly the experience that I had working in Victoria, that we were very much an autonomous nursing team. We had the capacity to make clinical decisions based on knowledge and the ability to rationalise them with our colleagues, and are often able to initiate treatments that in some areas are very much restricted and require your medical personnel to do the review before they can be initiated. Certainly in Victoria, where I did most of my work, we would be able to, within reason, and so long as you were deemed to be a senior staff member, we could make judgment calls about whether we were going to start noradrenaline on some of our patients, if we'd already gone down the pathways of making our assessments based on our cardiac outputs and indexes, how that patient was clinically, and with the knowledge of what they were like intraoperatively. If we've already done our albumin boluses and things weren't improving to the parameters that had been set for our guidelines for treatment, we could certainly make that next step and go to the decision-making process of starting noradrenaline. We would obviously discuss that with doctors, but often that discussion may be retrospectively, given that the acuity of that unit was quite extensive. And given some of the technologies that we had in that unit, we had a lot of ECMO patients. That was very common for us. Heart transplant patients, ventricular assist devices. The patients who require good clinical judgment and cannot afford to wait for a doctor to come to them when they're ready. So things like waiting for doctors to finish a ward round was totally impractical, so it was very much governed by nurses having the knowledge of the underlying pathophysiology, knowledge of the devices itself and how that all interplays with each other with acutely unwell patients. So those kind of patients required us to make decision-making processes very quickly, and hopefully, in the majority of cases, we were correct. But we didn't always have the luxury of having a doctor who could come to us at any time.
So the patient's best interests were always at the heart of your practice.
Yeah.
And you're always critically thinking of the situation.
Yeah. Otherwise, those patients' outcomes could be very different. You don't have the time to wait 5 or 10 minutes in those patients, and you need to do what's going to optimise their outcome, even at times, even if it probably does exceed some of our scope of practice on that little bit. But I suppose scope of practice is sometimes also relevant to the areas that you work in as to what culturally is deemed appropriate in those clinical areas. That varies, I suppose, considerably to some of my other clinical experiences in other units in other states, where your ability to make an assessment on an arterial blood gas and then factor in what you're going to do with the ventilator was completely out of the hands of nurses. Quite a foreign thing to be told that we're not allowed to make clinical decisions on weaning and changing ventilator parameters when you have the background and you've always had that knowledge and expectation of people to be able to make those decisions. So it does vary quite considerably, I think, given where you work and what the expectations are. Some units are very protocol driven, so protocol says this, therefore you cannot do that, although in other areas you'll go to work and there'll be expectation that you will do those procedures, and it's not even a matter of being referred to medical doctors for advice. The expectation is that you know how to do it, you know the rationale for it, you know the complications, and you should be able to manage that within reason.
Gee, that's fantastic. That's very, very helpful. So it would be very challenging sometimes moving from one place to the next place, where you've got expectations, where you've been working to a level of practice in one centre and have recognition by your colleagues that you're a capable nurse working in that environment, to suddenly move somewhere else where it's quite different. How do you address some of those challenges?
I think a lot of time it's quite confronting when you find out that sometimes those parameters are being changed quite dramatically to what you're used to, and it does take a while to find your feet, I find, to settle into a new place, to know where your position is in the context of the overall team. And I think just being open-minded and having the capacity to listen and observe what happens within the clinical areas, and always, I suppose, asking those questions as to why, what's the rationale behind things, and where does the evidence come from for the practices that are undertaken in various units, because we know that some practices aren't always governed by the best interest, and sometimes a reactive component to it from an incident that may have happened in that unit some time ago that has now impacted on the way they undertake certain activities. So I think it's important for students and for any nurse really to be really quite questioning of what happens in that environment. It only helps you better understand what happens, but also gets the opportunity for you to get further knowledge about the practices that are going on in those areas.
That's been so helpful, Laurie. Thank you so very, very much for helping out today. And if anyone's got any questions about anything that you've said, I know you're very welcoming of questions and discussion, and I'm quite sure that we can email you and get some advice.
Absolutely, no problem.
Thanks
you,
so
Laurie.
much, Laurie. Bye for now.